This next session, about culturally competent child psychiatry, and it will be moderated by Lauren Packer, who is making her way up to the podium now. Thank you so much, Lauren.
One. Hey. Hi. All right. So I'm Lauren Packer. I'm a therapist. I own Packer Counseling in Hoover, Alabama. I'm going to be moderating today. So before we get started, I'm going to let our panelists introduce themselves. And then we will get started with this conversation about culturally competent psychiatric care. Say that 3 times. Yes. All right. Dr. Nelson, you want to introduce yourself?
Okay. I'm Dr. Artie Nelson. I'm a child adolescent family psychiatrist. I have an office in Hoover and an office in Madison. I see ages from as young as 3 all the way up to 80 years old. My interest is ADHD and also cultural psychiatry. I do a lot of cross-cultural lectures around the state. I just got back from Selma where we did a talk on racial trauma. So that's my sort of thing that I like to do.
Okay, Dr. Martinez.
My name is Dr. Martinez. I'm one of the psychiatrists at Children's of Alabama. I'm the medical director of our PERC, our Psychiatric Intake Response Center. And for those that don't know, the Children's of Alabama Emergency Room, we have a psychiatric consult team, and I'm the psychiatrist that works in the emergency room at Children's of Alabama. And it's in such great demand with the mental health crisis that we have right now. We recently just expanded our emergency room space from 4 beds that we used to overflow into the emergency room like the regular ER. Now we have a 16-bed pod area just for behavioral health patients because we're seeing that many patients on a daily basis in the emergency room.
Yeah. I work with teens and tweens, so I'm pretty sure you got some referrals for me. All right, so today's talk is all about cultural competency in psychiatric care. So I think that we should start by defining what is cultural competency and how does it relate to mental health and mental care.
Start. How I see it, and I'll give you a little background. I trained in Los Angeles, UCLA. There was a King Drew Medical Center and Cedars-Sinai Hospital. So we saw a diverse group pretty much from the beginning of my training. Started out as a pediatrician and went into child psychiatry. I would define it as taking a patient or a client's culture into consideration when you are doing your initial interview, when you're doing your therapy, when you're trying to make a diagnosis or evaluating. So keeping that in mind. And we had been stressed to look at the culture first. The father may be different in the way they act in their culture. The mother may be different. The family dynamics may be different. So I always suggest that you throw that right out in the beginning. How do you feel about coming to see a mental health professional? How do you feel about seeing an African-American mental health professional? If you're not African-American, those things, throw it out there, because what I've seen in my experience is that that's in the room, but a lot of times people don't talk about it. And then 6 months later, that was an issue. So that's my definition.
Well, I'm from the small town of San Antonio, Texas, and I came over here. So it's a big cultural shock. I graduated from medical school in San Antonio, Texas, and came over here to Birmingham to UAB for my general psychiatry residency, my child psychiatry fellowship, and then I stayed on as an attending at Children's of Alabama. And the way that I help our fellows and residents and medical students and our other clinicians understand cultural competency, why it's so important, is because in mental health, clinicians, we have checklists and we have boxes that we go through, and we just go through and click, click, click. And with technology and EMRs, it's just getting so much more easier to click buttons and give a diagnosis and say, oh, they're angry, they're upset, mom is loud, their mom must have some sort of bipolar disorder, mood disorder, but not really taking into understanding like cultural aspects. If they're the family is like Dominican Republic and she's not loud, but that's just how they communicate and how people communicate with each other. More people are more active and animated versus some other like Hispanic cultures are just kind of more like calm, don't give a lot of eye contact, head down, nodding. And so in working with the clinicians that I train, we always have to take a step back and have a bigger understanding. And that's what I see is important with understanding like cultural competency.
Yeah, and to piggyback that with another question, so as you are teaching these future clinicians or clinicians in training, how do you help them with their personal biases against other cultures, right? Because I'm Black, so I can very much say, oh, I could be a clinician to any other Black person, but that's not true. Every Black person doesn't have the same story, or a white person can come and sit on my couch and I'll be like, it's not going to work. So how, because of my own biases, so how do you train other clinicians or lead them to getting rid of their own biases or compartmentalizing?
So in the emergency room setting, and if you can imagine in the we see a wide range of presentations and people coming into the emergency room. And it's really important, and especially working in mental health, is having an understanding of not taking things home with you, being non-biased, non-judgmental, just having, trying to take a step back and looking at the bigger picture. Because when everyone, sometimes patients come in, it's important to have whoever you're working with not automatically get upset or feel that they're being attacked or blamed or something for the mental health system that is failing this parent and this child. They're not mad at you, they're mad at the system. And helping clinicians I work with just take a step back and take a breath and know that they're not mad at you. The mom is not yelling at me. She might be yelling at me, but she's really yelling and she's frustrated because she's at a loss. She doesn't know what to do. Especially with mental health, we already know there's a stigma, and a lot of people are not out loud proud and saying, I'm going to the emergency room, I'm going to take my daughter or my son. It's more like their own personal crisis, like, I don't know what I'm doing as a parent. I may have failed. I'm struggling. I don't want to tell my parents or my mom, or they're just going to say that I'm crazy. And so it's important to make sure that people that you're training and working with have that understanding and not just go in and make a personal bias or get upset or frustrated.
Let me add to that. I do a summer session for the fellows at Children's Hospital on cultural psychiatry. And what I like to do, maybe because I trained in Los Angeles and in the movie business, I actually show videos to them of different situations. There's a couple of them that are out there that are put out by the government that shows these interactions, but they're also just regular movies that have come out that I try to show them how a different culture behaves. And I will show, I don't know, many of you are familiar with Something the Lord Made. It's a movie came out years ago about Vivian Thomas, who was famous for the blue baby surgery for kids. And I show that movie just to show, particularly when it's not just an African-American population, but just to show them a history that has happened, why people need to know about different people's history. And we show that movie and then we discuss it. Also have a video of individuals talking about their experiences. Another video that shows Asian American experience, shows Arab American experience, different experiences. And they talk about how they were treated in this country when they first came. I work with medical students in my office. They talk about how when they moved here, how they were treated, and how coming from a country where everybody looked like them and then coming to America and getting a different treatment. Some of them are doctors now, some of them are still in school. So it's very helpful to just show. I think visually you can show. You can also tell them to read things, but I think visually it's very important too.
Okay. What are some of the challenges that you all have seen as psychiatrists who are practicing to be culturally competent, especially you, because you're in the ER, so you just get whatever the wind blows. And so what are some of those challenges? Because everybody know we need a good story every once in a while. So what are some challenges, or what has been some of the most difficult things that you've seen?
I mean, some of the most difficult things, and that is very hard to explain, have people understand, is how the system is not set up to help people the way we want it to help people, or that would be beneficial. There's a lot of turnover with mental health clinicians and with social workers and DHR. And once you have a good therapist or a good person, a lot of times they change and they find a different opportunity, or they continue to get their own education, which I can't tell you not to get your own education, but they're going to leave that family and go to the next thing. So with our mental health centers, high amount of turnover with therapists and psychiatrists, and everyone is overworked and overburdened. And for me, that is one of the biggest challenges in working in mental health and working where I am, where you have a family and you're talking with them, and they feel they make a good connection with somebody, and then the connection breaks. Not because of the family, not because of no-shows, just because the clinician had to turn over and went to a different opportunity, or more money, or more education. And so that's one of the biggest challenges that we have, especially with pediatric and working with mental health patients. And that's one of the benefits, and why it is very important for programs that myself and Cindy work with our Psychiatric Intake Response Center, because we're constantly having to update our database and call and reach out different counties and clinicians and people that have started new practices to make everyone aware and provide these services and resources.
Yeah, you led me into stories, so
Go for it.
be careful. I can tell you several stories. I'm going to tell you one. I used to consult, used to be called Oak Mountain Adolescent Center there in Oak Mountain. It was owned by Bradford. And I saw a young lady, 14, from a Native American reservation in Oklahoma. Somehow she ended up in Alabama. And when I saw her, she kept asking, I need to go back to the res. And I didn't know what the res meant. I thought it was another residential place. And come to find out, I had a Native American patient, and I asked her about it, and she was very politically involved. She lives in North Alabama. She goes to the Congress and testifies, that sort of thing. So I asked her, I said, well, what's the res and what does that mean? And she said she wants to go back home. She wants to go back to the reservation. And the treatment team kept trying to make her fit in with this system. And like Dr. Martinez said, the system is clearly broken, and she was not doing well. She was acting out. Long story short, we kept advocating for her to go back to the res. Now we connected. I think you really have to get to know a person's culture and connect with them. So we talked about her tribe and things like that. But eventually she did get back to the res. We called back. She was doing a lot better. She was back with her family or back with her tribe. So we know it's important. I think the biggest thing is in that story is getting people at least to be recognized for their culture. And I know it's hard sometimes, particularly when you have so many minutes to see somebody and that sort of thing. And like you said, the system, people move and they change. But if you can take the time and just listen, that's the whole empathic response, to listen to people's stories. And if we have time, I'll get into that a little bit.
Yeah, you can.
But a main thing I wanted to share with you, another story. I was seeing a movie director in Los Angeles, and he was having anxiety, and we were talking about his next movie and things like that. He's actually doing pretty well now, but he said, every movie, Doc, is the same story. And I said, well, what do you mean? He said, well, in film school, they teach us about how to make scripts and all that. He said, it's the hero's journey. I said, well, explain that to me. He said, every blockbuster movie follows this pattern. And the pattern is there's a call to adventure. You take that call or you don't take that call. It takes you a while before you decide. Then you go into the abyss or You separate. It's like going to college. If you go away to college, that sort of thing, that's that call. You meet people on the way that help you. You meet people on the way to try to sabotage you. But eventually you come to the ultimate point where you change, you get that degree, you find that job, and you come back home and you tell the story. You come back and you start a foundation or you help people. So everybody, he said, has that. And I did a conference about a month ago, and I went around the room and had people raise their hand. What's your favorite movie? And when you describe your favorite movie and why do you watch that, or you can watch it 10 times and not get tired of seeing it, it follows that same pattern. The guy was Joseph Campbell. He's the one that came up with this. He traveled all over the world, and every culture has a hero's journey in their story. And so I tested it out. I started asking people from different cultures. Hey, I met a guy from Nepal. I said, do you guys have a cultural story? And he said, yes. We had this king and queen, and they were kicked out, and then they came back, and they started, and then they took the country back over and came back and started again. So we all have that. And I think that's what the attraction is to, even in the mental health field, to hear people's stories and try to help them on their journey. So I wanted to show that one slide. I had several slides, but at least that one.
No, it was
Okay.
awesome. And so with that, what do you do for cultures where belief trumps the science part? Like, how do you handle a culture that says, my belief is that we can go do all of these other things, and you're like, but you have this difficult diagnosis and you really need mental health care? How do you mix the cultural competency with what actually needs to be done?
For patients that we work with and provide education, it's really important to ask that question, because sometimes you have the new clinician or the brand new medical student or the brand new social worker come in and voice frustration on a family, saying like, mom is just not getting it. She doesn't care. She doesn't want to give the medication. We need to call DHR or get the social worker involved, because that's neglect, because they don't want the medication. Or mom's upset, or the family's upset because before I start the medication and provide education, I have to get grandma's permission, because the grandmother is the matriarch or the person that has the understanding. Or in some families where maybe mom graduated from high school, or dad didn't graduate from high school, but there's an aunt or an uncle somewhere that has more education, and they want that person involved, and it's on a telephone. All that to say is it's important to remember to have some patience and understanding with the family and who you're working with. And sometimes we'll have sooner follow-ups, or say, if this is outpatient, we'll talk about what the treatment plan is. And of course, we want to do therapy, of course, encourage and promote their faith and religion, and invite them to continue to practice that. And I always say, but if that doesn't work, we need to discuss, the medication, and just start a very low dose of medication. Sometimes I'll just hand a prescription and say, this is going to be there at the pharmacy. You're going to take your time, do your research, talk to your family members, but it's there for you. I'm not going to push it. I'm not going to do that, because a lot of times we have to have an understanding that in some cultures, giving the medication, one thing that I've always get told in the emergency rooms, I have a family member with addiction. I don't want to be dependent on your pill. I don't want to take the nerve pill because I don't want to end up like my aunt, who had to go to rehab, or is at the Love Lady Center, or is struggling. And so having that understanding of what is the concern that they have about the medication, whether it be addiction, whether it be they feel like it's going to change their personality, and not pushing things. So I really don't want to push the psychopharmacology or the medication until I'm sure that the family and the parent has an understanding, and being able to and willing to take that extra time. And that's where we really struggle with medicine nowadays, is we don't have time because of our EMRs and documenting and charting and billing and everything. We just don't have time. And that's what a lot of families deserve, time to take an understanding.
Do you have anything?
Yeah, just to add, the elephant in the room, I think we have to talk about racism, white supremacy, as fueling some of that distrust of the system. We all know the history of Tuskegee, and I just found out there was something that happened years ago in Georgia at Emory. And at Johns Hopkins, there were some things going on. So I think we got to talk about that part too, the distrust, particularly of people of color with the system. I try to throw that out again right from the beginning and say, look, I know you have some concerns about medicine and what this might do, or people have been experimented with, that sort of thing. So we can't forget that part. I do that again when I teach residents and fellows to talk about that. And it's very easy to kind of say, okay, that happened a long time ago and it has nothing to do with now. But we know that implicit bias is still there. We know that African Americans are diagnosed and Latino Americans are diagnosed more with bipolar disorder. I see people that have this diagnosis of schizophrenia but have never hallucinated, carry a job, they've been to college, but they got this diagnosis of schizophrenia. And I'm said, who gave that to you and when was that? It was 10 years ago. And, they're on 5 different medications and no one's tried to take them off or reevaluate. So we know that's in the room. And I think it's naive for us to not go in there and say, how has this impacted you? And you almost feel the relief when you bring that up and say, how has racism impacted you in your job or at school or in your education? I had a student that's rotating with me now, and he moved here recently to go to UAB, but he moved to New York. And he's again said when he got to New York, he had all these images of how New York was, and he got there and was mistreated at his job and all this stuff that had happened to him. And he said he was trying to figure out in his head why it was. He had to go see a therapist. He was anxious. He was having panic attacks. And I had to say it was racism. And he said it, and his brother told him that it was racism. He said there's nothing else that was going on. You're smart, you're intelligent, you're going to get into med school. That's the only thing it could be. And once it was a relief, once he found out that's what it was, he was able to navigate that environment. And that's, again, the racial trauma of that to actually have to go through that. I think we have to be honest and bring that up. So that's a challenge in itself.
Are there any other challenges, right? So we've had a whole pandemic. We have racial trauma. There are also increases in eating disorders, anxiety. So what are the trends that you all are seeing across cultures in your psychiatric care?
The one of the things that we have to be aware of, and especially what Dr. Nelson mentioned, is like misdiagnosis. And there are studies that show that if you're a minority, if you're Black, and you have symptoms of ADHD, it's more likely you're going to be diagnosed with oppositional defiant disorder versus if you're Caucasian and you have symptoms of ADHD, then you're given a diagnosis of ADHD. But just having that diagnosis of oppositional defiant disorder already puts a negative stigma and negative beliefs in that patient. Like, oh, okay, well, they have ODD, which is going to end up being conduct disorder if they're not going to get any treatment, or it's just going to get worse. They're going to get conduct disorder. And then when they grow up, it's going to be antisocial personality disorder, and they're going to be in jail and detention and just put in the system in a negative way. What we see at times, we have, of course, with the emergency room, we have a lot of turnover and new people and new therapists and new physician assistants and nurse practitioners. And they all love to come in and start off and say, like, I don't know why mom is here again for the 10th time. I told her to call the police. I told her to get a CHINS petition. And if you don't know what a CHINS petition is, a child in need of services, she just needs to deal with that and send him to juvenile, send him to detention so he can learn his lesson. And everyone gets frustrated why the mom is not doing that. And we have to take a step back and have an understanding that she's not doing that, because if she does that, the chances of the child getting stuck in the system and getting not the treatment they need is so much more higher. And so that's why the mom is not doing that. That's why she's here and saying, like, it has to be something else. It has to be depression or mood disorder or something. There has to be another intervention. And then looking at insurances, if you have Blue Cross, You can get an appointment fairly quicker than if you have Medicaid. And with Medicaid, there's all those loopholes that you have to jump through, and getting a referral and making sure you have your yearly wellness check. The child has to have a wellness check. And you can't go for a referral for mental health on the same day you have a wellness check, because Medicaid doesn't let you click that box. And it's just so frustrating. But having an understanding of the system is what we have to do, especially as clinicians, and help guide parents and help guide those that we're working with. And so when you're working and you have an intern working with you in social work, getting their hours, making sure they have that understanding of systems so they can not overly and misdiagnose people and send them down the wrong path, or send them down a path where they're just going to get stuck in a negative part of our broken system.
Have anything?
I think the other challenge is certainly when they have medical conditions also. Dr. Madden Swain at Children's refers kids and their families when they are diagnosed with cancer. And that's a devastating diagnosis in itself. But imagine coming from a small rural town in Alabama and coming to the big city of Birmingham and staying there for treatment for weeks or months. So that's a challenge, in making them and helping them navigate that whole system, to find places to eat, to do certain activities with the other kids. I've had patients where the other kids are still 2 hours away, and mom is here trying to take care of the kid that has cancer, but dad's there trying to take care of the other kids, and it's very, very devastating. I had an opportunity, and I always say, listen to the people you're talking to, hear their story. I had a young lady that she lost, I saw her about 16, she was depressed, lost her brother to cancer. So they somehow found out, and Dr. Madden Swain referred them to me, but what we were talking about was a book she was writing. And she was writing about the experience of having a sibling pass away with cancer. And it still rings with me. She talked about, hey, have you ever been frustrated with people driving in Birmingham and jumping in front of you and speeding and flipping you off and all this kind of stuff? And I said, yeah, that does happen. She said, imagine if that's somebody's family trying to rush to Children's because they got that call from the doctor that they got one more hour to get here. Things are not looking good. And I'd never thought of it that way. And this is coming from a 14-year-old. So you never know what a person's, again, back to this story. You never know what that story is. I hope she finished her book, but I really encouraged her to finish that book. It could be really helpful for other families. So that medical challenge is just as much as the mental health challenge, where Medicaid doesn't pay for a lot of things that they need. Their chronic disease goes on for weeks or years before they get seen, and they know there's only very few Medicaid providers. I'm one of the few private people that still take Medicaid. And I'm really surprised because a couple of doctors will call me, well, what's the process of getting on there? I really do want to see some Medicaid patients, but then the process is so hard to get on Medicaid as a provider. So those challenges are there also, the medical challenges.
Yeah, and speaking of challenges, so while we're talking about cultural competency, how are you handling when you or a patient don't speak the same language? Like all of those different barriers that kind of interrupt just the baseline process of therapeutic care. Sorry, y'all. So like communication styles, cultural norms, language, how do you handle that?
It's interesting you say, because when you say like communication barriers, obviously, being Hispanic, I'm thinking like, oh, because they don't speak English or Spanish. And that's not always the case. And not really until it's not until you actually have to go through it, of course, is that when you're most humbled by or have an understanding. Like when my wife, when we were having our first baby and then our second baby, it would just be so interesting to know that we would have an interpreter come in with the team, because automatically they didn't think that we spoke English because of our name. And at UAB, and I'm a physician, but they don't see that. And so we would just shake our head and like listen to all the questions being in Spanish and answer back in English. And so sometimes you got to think about those language barriers. But what I really think that question is when you don't talk the same or have the same meaning, or words don't mean the same or something, when you have an older male patient or an African-American patient said, I don't want to take your Prozac because it's going to mess with my nature. I don't know, what do you mean by your nature? What are your nature? And then having that understanding, you have the student come back saying he doesn't want to mess with his nature. What is that nature? Is it because he's hearing voices or seeing things? No, that's not what it means. It's talking about his sexual drive, his libido. That is nature. That is his nature. That's what he's saying. And having that understanding and being able to talk at a level where you're not talking down to them. You're not being rude or disrespectful, but making sure that when you're talking about a diagnosis or talking about a treatment plan, you're saying appropriate words that everyone's able to understand all together. And sometimes as a professional, it's hard to, we pride ourselves that we have our education, we have our IDs and badges and letters behind our name, but I don't know everything. And I didn't know what nature was when I was a first year intern at UAB in the emergency room and hearing that stuff. I was like, what are you talking about, sir? But now now that I know, taking that knowledge and sharing it with others. And that's one of the important things in understanding communication barriers from my point of view.
Okay.
Yeah, again, I would agree. I think just listening, we had the luxury at where I trained to have on call any language you wanted, and they would be there in 5 minutes, in the hospital. It was just that luxury, but it was difficult. I did a rotation at a U.S. embassy in Los Angeles where you had every possible culture that they would come to Los Angeles for meetings and that sort of thing. And some would live there for a year or so. Again, I'll tell you a quick story.
Of course.
This young lady was from Australia, and she came with her dad to be educated for her last few years in the U.S. She got around the wrong crowd in Los Angeles. It's not hard to do, and ended up experimenting with some drugs, was sexually assaulted, and tried to commit suicide. So she was admitted. She was my patient. Little did I know there is an issue in Australia regarding race. And the dad was uncomfortable with having an African-American physician, psychiatrist. Didn't know that going in. Talked to my supervisor and said, yeah, the Aborigine, there's some issues there, just like there've been in America. So he was real quiet. I don't think he even shook my hand when I walked in the room. But, I kind of took it and said, okay, I'm here to help your daughter. In those days, you could stay a month in the hospital, believe it or not. And you could go to school and come back to the hospital. Long story short, we connected pretty well. She got better. We hooked her up with a therapist that understood the culture. This dad came in with tears in his eyes on the day of discharge and said, thank you. I really didn't respect the fact that you were going to help my daughter. And, he tried to make amends, so to speak. But it really kind of touched me that, the importance of really connecting and listening and finding out about the culture. And again, some of these people still call me back years later and say, hey, I'm still doing okay. How are things in Alabama? They were worried about me going to Alabama. That's a whole nother story. But and I said, it's great. It's much better than you think and what you imagine. But it's really important. Like I said, the cultural part really made me more interested in psychiatry. Pediatrics, when I was doing pediatrics, it was just a matter of, we used to call it one big ear infections. You look in there and give them an antibiotic and they were gone in 5 minutes. But this really helps you get to know yourself, and if you're willing to learn. And people look at you as the expert and they admire what you do. And I think we take that for granted sometimes. In the hospital, I had a guy that worked in maintenance come up to me and said, I'm really proud of you. And it really got to me, and I was like, he said, yeah, you've done something that, a lot of us haven't been able to do and all that stuff. And a lot of times we forget that. We're walking around, we're the professionals and mental health professionals, and we're taking care of people and we got our degrees, but they admire people that come from rural North Alabama somewhere. And you can, Caucasian, and not really know about education, and they have a white therapist that is very educated, and they're proud to see a young person doing well and that sort of thing. Hey, I wanted to go to college and that sort of thing. But I think if we don't take the time to communicate, we don't get that in the interaction.
I agree. Well said. So speaking of us as clinicians being culturally competent, is there a thing as a clinician being overly culturally competent, and how does that hinder the relationship or the therapeutic process?
One thing that I always that I learned very quickly is I take out the word I understand. When anyone tells me something or they're saying, clinicians will say like, I understand you're in a bad place. I understand. I took that out of my vocabulary. I never tell a patient or a family member, I understand what they're going through. Even though I feel like, oh, maybe I do understand a little bit, but there's no way that you can understand the lifetime that this person has had, the adversity they've had to face, and the discrimination or whatever is going on. You can never understand everyone's traumas or their background or their culture or anything. And I think that's really important. And I always reinforce that in working with our clinicians, that we don't tell a mom, like, I understand what you're going through. You're here because your child is not sleeping and they want to murder you in the middle of the night, and that's why you're here. You don't understand what it's like to be fearful of going to sleep because your child is not sleeping and screaming or nonverbal or autistic or something. You don't say that I understand to a patient. And I think that's really important because clinicians tend to get comfortable and they feel like, oh, they know how to work, and that they feel like all people that are Black are the same. We know culturally, you're not the same. And people have different backgrounds. All Hispanic people or Latinx people are the same. We are really, really not the same. Not at all. And even here in Birmingham, going from one restaurant to another, we're not the same. But the making sure that even within ourselves, having that understanding and letting people know that we don't understand.
And I think you can have almost a childlike curiosity. You really don't understand, like Dr. Martinez was saying. Have a childlike curiosity about that. People love to tell their story. They love for you to talk, even when it's you're in your head saying, "Oh my God, they've lost 4 people in the last 6 months, and some to trauma." But just sort of listen and have that childlike curiosity, and you'd be surprised. I know somebody was talking about during the pandemic, you take classes and all that. I took a master class in hostage negotiating. And it was an FBI specialist. So we were really getting bored. But they talked about mirroring. And I didn't realize about mirroring, where you repeat. And when you really get good at it, you don't even have to do the last three words of what they say to you. And you'll be surprised how much more information you will get. If they say, hey, so-and-so died in the last 2 months. In the last 2 months. And you think they pick up on that, and they really don't. And then you can test it in this mirroring. And then you get really good at it. You can go halfway in the middle of the sentence and pick out 3 words. And they'll really just start to open up, especially if you're having somebody that's not saying a whole lot. Boy, it's hot outside. You can tell they're upset that it was hot. Oh, it's hot outside. Yeah, it's hot outside. And they start talking. I didn't really want to be here. You really didn't want to come here. And like I said, it sounds really simple, and you think it doesn't work, but it works every time. And like I said, it was a six class master class. And I just sit there, and he negotiates. This guy wrote a book and everything. He negotiates serious situations where there are hostages and all that kind of stuff. And that's what he uses to get people to kind of come down and put the gun down and that sort of thing. Sometimes it works, sometimes it doesn't. But I would share that if you use mirroring, it really does work.
Mm-hmm. I wrote that down. Did y'all write that down? Because I was taking notes. Okay. Last question, then I'll open up the floor to questions. Do you guys have any tips and tricks for adapting culturally competent care for us clinicians who are diagnosing and assessing before we send them to you all? Because it happens.
I think it's really important, especially coming to meetings and conferences and getting CEUs on topics like this. I mean, this is really important, and taking the time, because we don't have time, but taking that little extra time of looking up and researching, what it is when they're saying like, I need to go to church, I need to pray on it, and because we are holiness, and then not assuming like all holiness is the same or Pentecostal is the same, or looking at religion, and it's having to take that little extra time instead of being on TikTok later. Look at taking that time instead of looking at TikTok to look at cultural and have some better understanding of other people and your clientele that you're working with and those that you want to work with. But I'm not telling you to do the research on TikTok. I'm just saying, because we all know about social media. That's all I hear every day, kids coming in because of social media and cell phones.
Yeah.
I would just add, up to a limit, share your own story. That helps too. It humanizes you. And I think, tell them a little bit about yourself. It doesn't hurt. We know the whole thing about transference and countertransference, but it really does help to share a little bit about your story and tell people. I had a young lady that was being teased because she played the viola, and a lot of the other kids didn't play. They wanted her to play violin or something like that. And I shared that I played cello when I was growing up. My dad played the big upright bass, and I grew up in Baltimore, and imagine getting on a city bus with a cello and people looking at this young kid with this cello taking up seats and that sort of thing, and trying to stand up when the bus was crowded. But when I shared that with her, it kind of took again that off of her, that okay, this is not weird. And I always told her, a lot of the LA people that I would meet that are actors and actresses, that little bit of weirdness can help you with your creativity. Don't worry about what other people feel if you're seen a little bit weird. It can help. So I would share that too, that's how you can really connect with people.
I love it. Everybody be weird.
There you
Right.
go.
All right. So we're going to open up questions. I thought this was wonderful. I hope I did good moderating because I was real nervous. I have 5 minutes.
No, I have a question.
Oh, yeah. Go ahead.
I don't know if this is, there we go.
Yeah.
From our online participants, Alfonso asks, as two male clinicians, how do you think in the area of therapy mental health can we get more males of color to not only pursue treatment, but also enter the mental health profession?
Mm-hmm.
How to get more?
Yeah.
How to get more men of color to pursue treatment and also enter as mental health clinicians?
I would start with just saying and it's an ongoing thing to destigmatize mental health. I think it's easier said than done. I'm part of an organization, or at least consult with them now. Brother, Let's Talk. You may have heard of it. It's started by a local therapist, and we go into barbershops. And in the African American community, that's where a lot of things are talked about. Football games and all that stuff. But it takes it away from the clinical setting, and it helps to destigmatize mental health. The other thing is, I'm a model for other people. So I try to tell them what I do and say, this is, it's not always about just sort of being serious. And we talk about movies and that sort of thing. But I never tell a kid they can't follow their dream. And like I said, I share my story, but I never tell a kid they can't follow. And a lot of times teachers have told them, or their parent or somebody has said, no, you don't have the grades to be so-and-so, you can't do this. And I said, you never know when that light bulb will go off in your head and all of a sudden it fits in. And I know we don't have a lot of time. Can I do one more quick one?
Yeah.
Okay. And this is my own personal story. I shared this in Selma about 2 weeks ago. I started out in Baltimore and in Maryland. You have two tracks you go to. You go to work back then, or you went to college. And if you took the college track, you had classes and things that helped you to get into college. If you took the work one, you could work for Bethlehem Steel and other places up in the Northeast. So I was on the work track. My dad was a fireman, jazz bass player at night. So I was on the work track. You know, you get a pretty decent job back then, and 2-car garage, you could buy a car and all that kind of stuff. Somehow, about, I guess, 12th grade, I saw a TV show called Marcus Welby, MD. Y'all are too young probably to remember that, but the assistant had a motorcycle, and I was into motorcycles and mini bikes. So I said, man, if I became a doctor, I could get a motorcycle. Okay. So it wasn't that classic story of, you know, I wanted to take care of people since I was 5 years old and all. That was my initial motivation. I didn't know you had to take all these science classes. I'm 12th grade at this point. So I went to a junior college and basically did high school in junior college for the academic stuff. I would come home, and my wife laughs about this all the time. I would come home and tell my dad, man, you know, you can count with letters, not numbers. And that was algebra. But we had accounting and all that stuff. We didn't have algebra and all that because you were going to work. You didn't have to worry about that. You had to count your money and your checks. That's what they taught you. So I say all that to say you never know what that person's dream is, and it may happen when they're 30. It may happen when they're 40. I have patients that go back to school at 40 and they're doing something completely different than what they started out to do. So I would definitely tell that person to, you know, get examples, get mentors, find people that are doing what you want to do, and that can be your motivation to get more people of color in the mental health field.
Did you get your motorcycle?
Sure did. My wife made me get rid of it, though. You know, it's dangerous.
Any other questions?
I have a question. So for those of us who work with graduate students or supervisors or clinicians, is there a recommended modality for helping our students or supervisees really understand cultural competency and what it looks like in action and in practice?
I mean, it would be important for you to practice what you preach, and lead by example is really important too. And that is really difficult being a student because you're studying and taking tests, and you have this material to work with, and it's unless it's like with a cultural competency course, like Dr. Nelson helps our fellows, all that stuff is taken out. They're just learning check boxes and scales and PHQ-9, they're depressed, or the RAD, or all these other things. And so it's important that when you have someone that you're working with or that you're training or interns to take that moment to give a little piece of information or like a nugget or a pearl. Especially when you're teaching somebody, we always know that you can only tell them something, maybe give them 2 facts, don't overload them with something, make it short and to the point, and then demonstrate it, and then have them show you that they understand. And then if they can teach somebody else or explain it, I mean, that's how you really know that it's going to be ingrained in them. So I think that would be important.
Yeah, I would agree. I think there's no specific modality. I mean, I try to turn them to people that have written a lot of things about cultural competency and cultural psychiatry now. There are books that describe every possible ethnic group, how the father's represented, how the mother's represented, what the family believes in. So the information is out there. But again, the best way is to see it in action, to find out, like you said, it messes with my nature. When you finally find out what that means, that student will remember that for the rest of their lives, what that means. And that, you know, that again, with me, I'll have a patient that will tell me about certain things. And I said, never knew that. That's very interesting. And I'll go look at, you know, now you can just Google it and find out probably even more than you ever wanted to find out about something. But that would be the modality I would suggest.
And it's more and more difficult now, especially with the pandemic and after the pandemic, because we're losing a lot of the in-person contact and everything. And that's where you can really see cultural diversity and having an understanding of cultural competency. Because with telehealth and with Zoom, you're only seeing like this picture. You're not able to see the bigger picture or see the forest. You're just seeing a tree in front of you and maybe their head if they're looking at the camera correctly. And so it's a challenge now. And so it's been important to take on that challenge as clinicians, as mental health leaders and professionals, and take that into your practice, because that's the only way that we're going to have any change.
Any other questions? No. So how can we follow you? How can we interact with you?
I got a question for the audience. Is that all right?
Oh.
Yeah, I'm gonna put it back on you guys.
Uh-oh.
Anybody that's brave enough, raise your hand and tell me what your favorite movie is and why.
My favorite therapy movie is Goodwill Hunting.
Why do you like it?
The Therapeutic Alliance that grows, he was committed to helping that young man, and he broke some walls down. And he became vulnerable himself with his client, vulnerable enough to be humanized. And so it was just a beautiful process to observe. Yeah.
Anybody else? Yes.
Antoine Fisher.
Yes, excellent. I use that in my therapy when I still do therapy with some of my patients to get them to see the process, particularly when you're resistant to it. But everybody, like I said, if you go home today, you have a favorite movie, you'll see why it does ring with you. It's the hero inside of you, and you're seeing something in that movie. My all-time favorite is The Wizard of Oz. You know, that she had the power to go home all along, right? She just clicked her heels and went back home. But every movie has that process in it. So I would leave you with that.
Nice.
Thank
That
you.
was deep. I'm like, The Devil Wears Prada, because I love Meryl Streep.
There you go.
Deep in my audience.
It's still a journey though, right?
It still is a journey.
Yeah.
All right. Any other questions, or how can we reach you, interact with you, see social media, all the things? No?
Oh, she had a question.
Oh,
Yeah, we
I'm
got
sorry. Go ahead, please.
I just wanted to thank the two of them. I've worked with them both for years, and their presence and just who they are
Yeah.
in terms of interacting with patients is
Okay.
phenomenal. Whether it's inpatient, outpatient, but I don't think they realize over the years just the difference that they have made in the community. Especially with, just a lot of our challenging patients and families that come in with clearly just a multitude of things that they're presenting. And so outpatient, inpatient, both of them, they're accessible, they're very fair with families, and the feedback that I've received over the years about the two of them is just outstanding.
That's so awesome.
Thank you. Thank you.
And I know that that's not fake. I know she means it because she's seen me as a resident when I was first rotating, when she was working with an attending, Dr. Aderoja, and then she's seen me next come back as a fellow, and then she's seen me come back as an attending. So I thank you so much.
Thank you. Thank you.
Any other questions? Okay. Well, I thank you all for letting me moderate. I thank the doctors for it, because y'all are really a vibe. It's a thing. Male clinicians in mental health are like a unicorn. Y'all know that. And so I think it was wonderful. So we're done. I think we're going to take a break and then get ready for our next session, but don't quote me on that. So thank you.
Thank you.
Thank you.
Thank you.
Thank you.